Good morning, respected teachers and my colleagues. Myself, Dr. Himadri from IPGMR SSKMH. I'm DMPDT under Professor Gautam Dotto, and I'm going to present a case of common cardiac neoplasm in uncommon location.
Yeah.
So the case history is Mr. HM, 45-year diabetic hypertensive male. He was admitted in local hospital with history of progressive shortness of breath. He was managed conservatively, stabilized, and referred to us for further management. Thorough clinical examination was done, followed by ECG and echocardiography. ECG shows incomplete LPBB, and then we go for the echocardiography. The conflict becomes here. So, in background of spontaneous echo contrast, poor ejection fraction, and there was a mobile sessile mass in the LV cavity. It was seen and measured around 25 millimeter by 18 millimeter. And further echocardiographical parameters shows that there is presence of severe LV systolic dysfunction around 20 to 25%, and there was RV dysfunction present with TAPC of 13.7 and RVS prime of 9.4 centimeter per second, and there was presence of grade 3 diastolic dysfunction and valvular assessment, so only trivial TR, there was no. So what to do next? In patient was started on guideline directed medical therapy for heart failure with reduced ejection fraction with close differential diagnosis of thrombus and myxoma. We put the patient on anticoagulation and planned for cardiac MRI. In the meantime, coronary angiography revealed normal coronaries. So coming to the cardiac MRI, I have omitted the planar view and the first. So going to the directly to the two-chamber view, there was a lesion with stalk is also visible in the cardiac MRI also, but the presence of the mass in the non-dependent location, which is very interesting, and this was in the four-chamber view. Coming to the contrast enhanced images.
Go to the next, otherwise you waste your time.
Just triple inversion recovery and perfusion images with contrast. And this was the inversion recovery with contrast and delayed 25 minute sequence. And MRI was reported, and we discussed with the radio diagnosis department, and MRI was reported as 2.5 into 1.8 centimeter pedunculated lesion in the anterior free wall. Post gadolinium DTPS study, there was initial peripheral contrast enhancement, gradually increasing centripetally in delayed 25 minute sequence, suggestive of myxomatous lesion, and small AST of 14 millimeter with flow from left to right was also visible. And now in favor of thrombus, the clinical background, poor ejection fraction, and thrombus is more common lesion, and in favor of myxoma there was non-dependent location, thrombus is more heterogeneous than mass, no response to anticoagulation, and post GTPA, gadolinium DTPA study findings. And coming to that, cardiac myxoma was most common primary cardiac neoplasm, often in atrium. In rare cases, maybe ventricle. Manifestation depend on size, location, and mobility. They can result in classic triad of obstructive, embolic, and constitutional symptoms. However, occasionally the patient may be asymptomatic and diagnosed unexpectedly. So take-home messages from these cases are primary cardiac tumors are rare in spite of benign histological condition. They can lead to unfavorable consequences. The shape, extension, and site of attachment, involvement of the valve leaflets, and functional obstruction of the LV outflow tract can promptly and safely diagnosed by echocardiography. Surgical resection is the definitive management, followed by histological confirmation. It's very difficult to differentiate between thrombus and myxoma. I was looking for some literature reviews. There was said that it was in echocardiography it was thought to be myxoma, and MRI confirmed as myxoma, but after surgical resection histopathology they came out to be thrombus also. In our case, the patient, after discussion with transplant team, it is enlisted for cardiac transplant. Then after we'll got the histopathological confirmation. Thank you.